require four things. The first is a life course approach to the prevention of chronic conditions. At every point along the life course, you're never too young and you're never too old to benefit from prevention. The premise here is that chronic disease, which is exemplified in this figure, develops chronically and progressively over the life course. For chronic diseases that are initiated, like HIV/AIDS at this point, by an infection, there is a point, of course, of risk. But for many diseases, like cardiovascular disease, they do develop chronically and progressively. And our goal is to slow those progressions so that they never become symptomatic. We know that, for example, as shown in these data, that risk factor burden at one age, like here, the burden of risk factors for cardiovascular disease at 50 years of age, for both men and women, matters tremendously in terms of whether people develop cardiovascular disease. You can see that men and women who had in the brown line 2 or more major risk factors for cardiovascular disease are at age 50 are at hugely heightened risk of developing cardiovascular disease at all subsequent ages, and particularly as compared, for example, to those in green who had a 5% risk if men and 8% risk if they had all their risk factors optimal. Huge differences that play out over the subsequent 40 years. And we know, as another example, that whether people become demented, whether they lose memory and mental functions in the oldest ages, is predicted by things all along their life course, by their educational level and in childhood and the environmental risks and stressors they're exposed to. At midlife, what their stroke risk factor levels are and whether they develop subclinical heart disease and even stroke. And how mentally active they are and what kind of mental activity we all have at middle age matters in terms of predicting cognitive decline and even dementia in later life. And even in late life, we have new data, and I'll show you a little bit of it in a few minutes, showing that how cognitively active and what types of cognitive activities you do, even what types of physical activity you do in later life, the latest years, predicts cognitive function. So we now know for cognitive function for many other diseases and for well-being in general that all along the life course, how we go about living changes the trajectories of where we're going. Going back to the issue of health disparities, we know that these risks are cumulative, or the exposures that people have. Different subsets of our population have worse cumulative exposures for bad risk factors all across the life course, and the cumulative effect of that is seen in older age. For example, from the same study I mentioned before, from Miller and Walensky, African American older adults manifest many more chronic diseases and disability 10 years earlier than whites. As a result, not, we don't think, of genetic predisposition, but of these cumulative exposures. So a life course approach to prevention is critical. In addition, going back to comments made by the people who spoke before me, we have to have a public health and clinical workforce that understands how health, prevention, and care needs change with age. Absolutely critical. I've already told you that with longer age comes serious health issues that are not found at younger ages. Geriatric conditions, multimorbidity, frailty, disability. Understand how to recognize those things, how to handle them when they co-occur, all of them in the same individual. Challenging, but doable. And we know, as I said, that diseases and conditions that someone has puts them at risk as they get older, in particular, for other problems. So it's not just what you're confronted with at the moment, but how you prevent the consequences of having those diseases that becomes part of what we have to think about. I showed you here the data from the cardiovascular health study that showed that actually when people develop heart attacks, congestive heart failure, and stroke, it puts them at huge risk of becoming disabled. But if you look at other data, here, for example, hearing loss, problems that people have like hearing loss actually predicts hugely in these unpublished data from the Baltimore Longitudinal Study on Aging the severity of dementia in subsequent years. So one risk factor, one problem, one health problem actually exacerbates the likelihood of developing other problems, and prevention strategies have to address that. Here you see similar data looking at whether people are obese in the blue, whether they have low strength in the green. This is for men and women 65 and older, or whether they have both in the red, both low strength and obesity. And you can see that if you have either one or both, that the likelihood of having difficulty in subsequent years walking is directly related to how many of those are around. These are not diseases, weakness. This is not a disease, really, obesity, although some of you in the audience might argue with me about that. But the disease outcome is not a disease either, walking difficulty. But these are major issues in the quality of life for older people, and they interact and have additive effects. There's also another category of changes that happen with age that are critical, and that is a decline in intrinsic reserves that leave people less able to tolerate the kinds of stressors that a 20 and 40-year-old can bounce back from readily. Paul Baltus hypothesized that at about 75 years of age, plus or minus, probably many years depending upon the person, that there's a real decline in intrinsic reserves, and that people need to be able to live independently, to be able to tolerate stressors. They increasingly need compensations added around them so that they can live in the way that they would like to. And these decreased reserves, therefore, necessitate new approaches to understanding who's vulnerable and what makes them vulnerable as they get older, and adds a necessity for all new approaches to prevention and care. Now, one way to understand this kind of vulnerability of loss of reserves with aging is the concept of frailty. And summarizing 20 years of research in one slide, we can characterize now an individual as frail if they have 3 or more of the 5 criteria present, that they have unintentional weight loss, weakness as measured by grip strength, slowness as measured by their walking speed, just walking a short course like 15 feet, low physical activity, and a sense of low energy or exhaustion. We have learned that people who have 3, 4, or 5 of these actually are frail and very high risk of adverse outcomes. And there is now substantial substantiation that this is a medical syndrome in itself that can be screened for and identified, even if people don't present with this as their concern. Now, why does it matter? Well, I'll show you several reasons. One is that people who look frail, and here's another way to look at these 5 manifestations, seem to be experiencing a very vicious cycle of loss of muscle mass and strength with age, declines in exercise tolerance and energy, slowing down, cutting back on physical activity, and in a subset, taking in less food and nourishment than they need even for low levels of physical activity, and when that gets really severe, being either undernourished or having frank weight loss. This is clinically a vicious cycle which can be kicked off at almost, it looks like, any point, whether by disease or by being inactive because one isn't feeling well. And people who have this presentation are at very high risk. We know, for example, if you look at the survival curve of mortality, that people who are frail, these are men and women 65 and older in 4 U.S. communities, are only 81% were still alive 3 years later. compared to 97% of men and women 65 and older who